children and pregnant women. Sarah received the Betty Hubbard Maternal and Childhood Leadership Award in 2007. She has an MPH from Harvard and a law degree from the University of Minnesota. And our third speaker is Tera Bianchi, who's the Oral Health Access Project Manager here at Washington State's Children's Alliance. So Tera, then Children's Alliance is a statewide advocacy organization here in Washington State, and as I said, I'm pleased to be on the board. Children's Alliance works to ensure that laws, policies, and programs work for kids. They do this through an advocacy process which includes mobilizing affected communities, using strategic communications, and convening coalitions. Tera has a master's degree in social work with a focus on policy from the University of Washington. So we're going to have a very great presentation today. David will be first, followed by Sarah, Tera, and then at the end, Betsy will wrap this up, and then hopefully we will have time for your questions. So with that, I will turn it over to David, and thanks everybody again for attending.
Thanks, Jack, and thanks for the opportunity to present. If you could switch to the next slide, please, that would be great. Just quickly, as Jack mentioned, my name is David Jordan. I'm the Dental Access Project Director at Community Catalyst. We're a national consumer health advocacy organization. We are celebrating our 16th year in existence, and we really work with organizations like the Children's Alliance to help partner with them to make positive change in the health delivery system to benefit consumers. Our history started with working on access issues, and now we have a variety of different projects, including the Dental Access Project. We're working in over 40 different states and really work to make sure that there's a robust network of advocates on the ground that can advocate for their interests, because we know that special interests will be advocating for theirs. Next slide, please. I start out every presentation reminding folks that oral health is important to overall health. Unfortunately, sometimes it seems like the mouth is separated from the rest of the body. According to the latest data from the American Dental Association, 181 million Americans went without a dental visit in 2011. And this is because of lack of availability of providers, because of cost, because of a combination of both. Nevertheless, oral health is important to overall health. So it's really unfortunate that, one, there's not always the recognition of that, but there's such significant barriers to getting access to care. Next slide, please. At Community Catalyst, we've been working to increase access to dental care since our inception, but we've been looking at adding a mid-level dental provider to the dental team since 2009. And have been helping partner with states since then. So it's really exciting to have been talking with state partners and having them talk with policymakers about the benefits of mid-level providers, the positive impacts they've made in Alaska, in Minnesota since then. Last year, we felt as if there was enough time to begin exploring some of the results of both increased access and the financial viability of these practitioners in Alaska and Minnesota, since both had been practicing for initial periods of time. So today I'll spend the bulk of the presentation really talking about this report, and then hopefully we'll have time at the end of the presentation for some questions. Next slide, please. So as I mentioned as background, in Alaska, the ANTHC began using dental therapists in 2005 as a way to increase access to dental care. Previous to that, there were some of the worst oral health outcomes and access issues in Native communities in Alaska throughout the whole country. So they developed a tribal solution based off of evidence of mid-level providers practicing since the 1920s. First, they trained dental therapists in New Zealand, and then they started their own training program in Alaska. Today, over 40 dental therapists are practicing in Alaska, providing routine and preventive care in Alaska Native communities under the federal Community Health Aid Act. And a lot of the care they're providing we'll talk about. Minnesota became the first state to license dental therapists through changing state scope of practice law. Today there's over 20 states that are looking at this option and 8 that have active legislation, including Washington, which is very exciting, to license dental therapists. I know Sarah will go more into the experience of Minnesota, but just since the first dental therapist started practicing and being employed by Sarah in Minnesota, we've seen positive results. Next slide, please. So as we've seen the evolution of dental therapists practicing in both Alaska and Minnesota, we wanted to really study who dental therapists were treating, the type of care they were providing, and whether or not they were economically viable members of the dental team with this report that we commissioned. Next slide, please. So to do so, we asked 4 providers in Alaska and Minnesota, 3 in Minnesota and 1 in Alaska, to provide us with data on the dental therapists that they were providing and the care they were providing to their patients. We asked for the amount of time the dental therapists in their employment were employed, their FTE status, their salary, their clinical setting, the procedures they were providing, the revenue generated for each procedure, and the age group and payer type for the patients seen by dental therapists. Next. The data we looked at was from August 11 through 2012. We looked at the practice of 8 DHATs, or 8 full-time equivalents in Alaska. We looked at 2 advanced dental therapists in Minnesota. So these are dental therapists that are able to practice under the general supervision or remote supervision of dentists. All the DHATs practice under the same supervision, and 4 dental therapists that work under direct supervision in clinics. So we looked at 8 full-time DHATs and 5.3 dental therapists and ADTs in Minnesota. We looked at the economic viability of DHATs, DTs, and ADTs as part of the dental team, and the providers were considered to be economically viable if the total net revenues from their practice exceeded the total cost of providing care. Next slide, please. So in terms of the question of where these new providers were practicing, I think it was confirmed that the new providers are employed by nonprofit organizations as well as private dental groups that serve a wide range of patients. The clinical settings in which they practice are urban areas, dental professional shortage areas, rural areas, and low-income communities. So they're practicing in places where we know there are problems in hard-to-reach populations. And the majority of patients seen by these providers were publicly insured children less than 21 years old. So again, practicing in typically rural inner-city underserved communities and treating low-income patients. Next slide, please. Looking into what type of procedures the dental therapists in Alaska and Minnesota were providing, we wanted to get a sense of whether or not they were providing mostly restorative care or surgical care. One of the big controversies around this issue is dentists performing extractions. While there's a tremendous amount of history showing that they provide extraction safely, and that experience has proved true in both Alaska and Minnesota, we wanted to get a sense of what percentage of the practice was extractions. And as you can see from the slide, it's a very small mix of the types of procedures they're providing. In fact, you'll see that the big groups of procedures being provided are evaluation and assessment, prevention, fluoride varnish, placement of ceilings, and restorative treatment, so filling cavities. Together, that routine and preventive care makes up 84% of the practice of dental therapists in Alaska and Minnesota. So I think that's really important for folks to understand that the care that's being extended to these previously underserved or underserved communities is preventive and routine in nature. Next slide, please. So in looking at the economic viability of dental therapists, we calculated that in both Alaska and Minnesota, for every dollar they generate, it costs less than 30 cents to employ the dental therapist. In Minnesota, it costs 29 cents for every dollar generated by the dental therapist. In Alaska, it costs 27 cents. In Minnesota, which Sarah can talk a little bit more about, this is really important because they're seeing a large percentage of Medicaid patients, 78% according to the study, and the Minnesota reimbursement rates are less than, are in the lowest tier of reimbursement rates when compared against other states. So the fact that this provider is generating additional revenue at a low cost to safety net clinics while only being reimbursed at a very low rate is really quite remarkable. Next slide, please. This slide really just shows the percentage of the number of procedures provided and then the revenue generated from those procedures. So where you're looking at the exams, the prevention, and the restoration, so that routine care, it's really an important mix to have that restorative work there, both in terms of revenue generated, but also to make sure patients' pain is alleviated. Next slide, please. So just a quick summary, dental therapists providing care to underserved populations, children, rural, tribal, and low-income populations. Over 50% of the total number of procedures performed by dental health aid therapists, dental therapists, and advanced dental therapists were preventive and evaluative in nature. And this suggests that these providers provide definitive treatment, the restorations, which is the other key component, and they provide access to evaluation, early intervention, and prevention, which is really where we want to spend our time as public health professionals, to making sure we're preventing the disease, but oftentimes the restorative work, that definitive treatment, is really a gateway to getting folks into the chair. Next slide, please. In terms of looking at Alaska and Minnesota a little bit more closely, the combined salaries of the Alaska DHATs was 27% of the revenue generated. 66% of the patients were under 21 years old. So in Alaska, they're providing care to adults as well, which is critical in some of these remote rural populations. The patient population served by the practicing DHAT is tribal, American Indian, Alaska Native, and to date, the over 40,000 people who previously had only intermittent dental care have improved access as a result of dental therapists living in their area and serving their people. So this is really a direct correlation between dental therapists practicing in places where there previously was not enough providers. In terms of Minnesota, the combined salaries for dental therapists and advanced dental therapists was 29% of their total revenue. 67% were under 21 years old. So again, adults are getting care from dental therapists as well, but a good amount of those getting care of children. This is a really pretty powerful number. 78% of the patients had public insurance. So this is really, again, amazing, because we know how hard it is to find dentists that treat Medicaid patients and how hard it is to make sure that Medicaid patients are getting access to care. So this really shows that dental therapists are reaching patients on Medicaid and also doing so in an economically viable way. And Sarah can talk a lot more about that. So, and practices are experiencing a positive financial performance. Next slide, please. Just a couple of quick conclusions. The practice of dental therapists in Minnesota is relatively new and should be assessed. There was actually a report that was just issued 2 weeks ago to the legislature by the State Department of Health that showed favorable outcomes for the program in Minnesota. And, you know, the more data shown, the more positive it is. So we're really excited to see more data come out of Minnesota. We do think there's future studies that need to be done, but given that DHATs, dental therapists, and ADTs are productive in various clinic settings, we see that there is a potential that they can be cost-effective members of the dental team, improve access to care, especially for traditionally hard-to-reach underserved populations. Next slide. I know we have sort of limited time, but I wanted to, as public health professionals, I don't want to rely just on one source of data to show that dental therapists are economically viable. There's over 90 years of experience that show that. But I did want to highlight for folks that are interested that Dr. David Nash from the University of Kentucky led a comprehensive literature review of dental therapists that found that dental therapists provide high-quality care to hard-to-reach populations. And I just pulled out a couple of bullets that I won't go through in an exhaustive manner that highlight that they also provide cost-effective care and help keep costs down in the countries where they're providing care. So the average cost of a school-based dental care in New Zealand was, for one child, was $100. In the private sector, an exam in New Zealand, very similar situation, was $102, where in the United States it's much higher. Next slide, please. And then also just talking about the financial viability. Pew has done a number of studies. The study that's highlighted here on this slide was done in 2011 that shows that dental therapists can help the private practitioners accept more Medicaid population and also continue to generate additional revenue and make it financially viable for their practice. Just last week, they released another report that was a case study on a private practice in Minnesota employing a dental therapist, and also a private practice in Canada employing a dental therapist. And both practices showed an increase in the number of Medicaid, well, in Minnesota, the increase in the number of Medicaid patients seen, but also an addition of revenue due to the practice of the dental therapist in that setting. And this is really important because there's 170,000 dentists in this country, and 167,000 of them practice in private practice. So the safety net is not comparable to the medical world, and we need to make sure that dental therapists are able to help private practitioners provide that important care to the safety net. Next slide, please. And that's the conclusion. So I look forward to your questions. Thank you for your time.
Well, good afternoon, everybody. Thank you so much for having me. And I have a number of slides. Actually, if you could please advance to the next slide. I'm going to try to just quickly go through some of our background slides. I am the director of the private nonprofit Children's Dental Services, which has been around since 1919, serving children and pregnant women across the state. Could you advance? Thank you. We are the primary provider of care in schools and Head Start centers across Minnesota. We also serve pregnant women. Next slide, please. Our target population is overwhelmingly low income. We serve more than 30,000 people a year. About 80% of those are on medical assistance. About 20% of them are uninsured, and we provide a zero-based sliding scale. So we provide free care to around 4,000 people a year. And people are not often aware of this, but Minnesota is an extremely diverse state, and more than 80% of those we serve speak a language other than English as their primary language. Next slide, please. So this is our service area. We again serve most of the state. And a point that I would like to make about this is I often get the question, how transferable is a dental therapy program to other states? And I just want to say that Minnesota, in addition to having the 17th largest metropolitan area in the United States, also has the largest tract of wilderness in the lower 48. And we have found the dental therapy model to be equally effective in improving access to care across not only diverse populations, but diverse geographic regions. And I think that's quite similar to the geography of Washington State. Next slide, please. Again, I won't spend too much time on this, but we do a lot of care in school and Head Start centers. We have a spoke and hub model, and we bring portable equipment out into the community. And we have found that our dental therapists, especially our advanced dental therapists who can work independently, are able to be an agile and productive member of that care team that actually goes out and provides care in the communities where low-income people congregate. Next slide, please. Again, we focus on culturally targeted care. We have a very diverse population. Next slide. And we target care to those who have a number of unmet needs, including language barriers, lack of insurance. And we do have in Minnesota, just like across the country, a significant lack of dental providers who will serve folks who are low income or uninsured. Next slide. David already mentioned this, but we have seen growing needs for dental services and have really focused on the importance of making sure that kids in schools are receiving dental care because of the significant impact that dental disease has taken on their ability to perform well and attend school. Next slide. So when we looked at all of the needs, when we looked at the specific geography and population mix of Minnesota, we came up with dental therapists as a solution for our gap in access to care because we found that the student population interested in pursuing dental therapy tended to be community-based. Many of the folks who have come to us through the programs have spent an average of 20 years in public health service. They have been more available than scarce dentists, especially in Minnesota where we have hygienists who had been underutilized, now getting advanced training so that they could bring their skill set again out into the community. We have found that the dental therapists are trained to engage patients and to naturally integrate preventive care and education into patient visits. They have gained expertise on a limited scope of restorative services. And so, for example, where a dentist may learn 250 competencies, the dental therapist is learning about 50 competencies, and those are the competencies that we tend to use every day in the provision of care to children. And what this has done ultimately is free dentists to practice at the top of their license and to focus on complex cases. Next slide. So a little bit more about the practice settings for Minnesota advanced dental therapists and dental therapists. They are limited to providing care in settings that serve low-income, uninsured, and underserved patients in a dental health professional shortage area. Now, I will say that we, on a personal level, my observation of the dental therapists is that it's very high quality care that is applicable in any kind of a setting, similar to nurse practitioners just working across the board in healthcare. However, our legislation was really targeted to meet the gap in access to care for low-income people, since that's really those are really the folks who are having a difficult time getting care. Next slide. So one thing that's caused a little confusion about Minnesota is that we have two different kinds of programs. We have a two-tiered model. We've got the advanced dental therapist and the dental therapist. And the primary difference is that advanced dental therapists have a larger scope of services, and they can ultimately provide those services independent of a dentist. So they work in a collaborative practice agreement with a dentist, but the advanced dental therapist can go out in the community and work without the dentist being present in the same building. The dental therapist, on the other hand, has a more restricted scope of services and will always be required to practice in the same building as a dentist. Next slide. So this is just taken straight from the legislation. These are the basic services that can be provided by advanced dental therapists. Next slide, please. And continuing. Next slide, please. Okay, so Children's Dental Services hired the first credentialed advanced dental therapist in Minnesota. We hired Christy Jo Fogarty. She joined us in the fall of 2011, and there is a period during which an advanced dental therapist needs to practice as a dental therapist, so with sort of a more restricted scope and in the presence of a dentist, until they gain enough hours to become licensed. And Christy Jo became the first licensed advanced dental therapist in January 2013. So for more than a year, she's been working out in the community. To the right is Elizabeth Branca, who is a longtime hygienist working for CDS. We supported her going through the program, and she is now graduated as an ADT. And we currently also have one other DT and 2 other ADTs on our staff. Next slide. This is another DT who we hired, and I wanted to point out when we were talking about representing the community, Meng Bang, who worked for us, was the first Hmong restorative provider that we had been able to employ. So again, we found that the student group going into the program more closely represented the community that we serve. Next slide. Again, another new dental therapist. Next slide. I'll touch a little bit on the collaborative management agreement. This is the formal agreement that enables or that defines the relationship between a dentist and a dental therapist. And we found it to be a really useful agreement that helps just outline planning, service protocols, communication, etc. Next slide. A couple of the hiccups that we've dealt with along the way, I would say that whenever you start a new program, credentialing and billing is a big, it's something new that insurance companies need to deal with when they have a new provider, but we have successfully worked through those issues. Next slide. I've been asked at times about malpractice and how concerned we need to be about quality of care. And I'll just say that the actuarialists who look at this find that dental therapists are low risk. And you can see this in terms of the what they charge for malpractice coverage. So for example, Marsh Insurance provides professional liability coverage for dental therapists at a rate of $93 per year. When you look at the average cost of malpractice insurance for a dentist, it's around $775 per year. So we find it to be low risk, and we have had no complaints about care for our dental therapists. Next slide. We do work utilizing teledentistry with our dental therapists. We serve remote regions. So that's one tool that can help connect our dental therapists and our dentists. It's not necessary, but it can be a useful, so for example, especially when we're working in a metro area, we don't tend to utilize teledentistry, but it's very useful when we are working in remote regions. Next slide. We have received interest, support, and funding for our dental therapy program. So we were able to expand the dental therapy program through a HRSA grant program. Next slide. This is just a little more of what I mentioned earlier, that because the program has been so successful, we have covered the tuition to encourage other dental therapists to get trained and to then join our program. Next slide. Hello. Is it possible to advance the slide? Oh, thank you so much. I have been asked if to kind of compare the cost of training in Minnesota between, oops, no, then it went ahead to, oh well. There we go. Thank you so much. To compare the cost of tuition between dental school and the dental therapy programs. And so this is information that came from the schools themselves. The average cost of Minnesota Dental School is $64,000 over 4 years, or a total of $256,000. The average cost for the advanced dental therapy training is $17,500 per year over 2 years, or $35,000 total. And the average cost for the University of Minnesota bachelor's degree in dental therapy is $65,600. And the first 2 programs do require 4-year bachelor degrees as prerequisites. Next slide, please. So then, now what I want to get into is just really how has the provider been integrating with our team. And we have found that overall, the efficacy of our team members. In other words, the productivity of the other dentists working in concert with the dental therapist has gone up. Next slide. This is just kind of restating that we have found some of our dentists saying, noticing that the advanced dental therapists, because they have a more limited scope that they're repeating over and over, that they're doing that scope often more quickly and more efficiently. Next slide, please. So this is an example of who our dental team is, our new advanced dental therapists are seeing. They're spending about 80% of their time so far in Minneapolis and St. Paul schools. Next slide. These are just other successful examples of integration. Children's Dental Services is one of several employers in Minnesota utilizing the model. Apple Tree Dental, Health Partners, Hennepin County Medical Center, Main Street Dental Care, and actually several others have recently brought on dental therapists as well. I think we're up to around 8 or potentially more employers here. Next slide. So what we've tracked through basically hand counting and Dentrix for all of our dental therapists has been number of miles patients travel to appointments, diversity of patients, number of emergency appointments seen, number of special needs appointments, and amount billed and received per provider. Next slide. This is a little more on the demographics. About 11% have been emergency cases, 72% have traveled more than 10 miles, 2% required hospital care, and we already discussed kind of the patient makeup. I do want to make one correction. Our DTs altogether have so far served more than 2,500 patients. Next slide. So these are interesting slides that show our production. August 2011 was the production of our staff before bringing on a dental therapist. Next slide, please. So August 2012 shows where our advanced dental therapists during that time measured up in terms of production. So you can see that they're holding their own. They are highlighted in yellow, ADT01 and ADT02. And one of them is in the top half, and the other is in the bottom half, but not the lowest in terms of productivity. So they are, again, keeping pace with dentists. And the overall production of the entire group raised since 2011 as well. Next slide. And this is about a year later, showing again an advanced dental therapist and a dental therapist and how they are ranking. Again, the entire group is becoming more productive, even factoring in any increases in fee structure, and the advanced dental therapists and dental therapists are producing consistently alongside dentists. Next slide. So when we look at that, this is actually a kind of a conservative estimate. If we assume that we spend $75 per hour for a dentist salary and $45 per hour for a dental therapist salary, and you assume that they can serve 1,500 low-income children and pregnant women per year, the cost savings for our clinic is $1,200 per week, or $62,400 per year, which really is allowing us to get 2 restorative providers for the cost of 1, and allowing us to expand access to care to that many more children, at least 1,500 more children and pregnant women per year, which with each dental therapist that we bring on. Next slide. So what we've learned is that the overall lesson is what I just showed you through the slides, that this is a high quality, productive addition to the team, which is making all of the providers produce more efficiently. We're seeing high quality of care, no patient complaints to date. We have found that being able to place, being able to work with an advanced dental therapist who can be an independent and not necessarily with a dentist is important, because when we have a scarcity of dentists, it sort of you know, hinders our ability to utilize that provider out in the community. And we've noted that the University of Minnesota dental therapy program is actually working on an advanced dental therapy track so that their providers, their grads, will be able to work independently as well. We also think for both dental therapists and advanced dental therapists, having a prevention component to the training is really helpful. And again, just overall quality of care has been excellent, and we are looking to expand the number of dental therapists and advanced dental therapists that we have in our program. Next slide. Thank you all so much. I'll look forward to answering questions later, and also my contact information is here. Do feel free to contact me at any time with questions.
Thanks. So my name again is Tera Bianchi, and I am the Oral Health Access Project Manager for Children's Alliance. I am really going to take a minute to, within this presentation, to talk about workforce as one strategy and kind of a tool in the toolbox for increasing access to care. I think David and Sarah really did a great job of outlining how that's working, and I wanted to just make sure that we unpack that a little bit and talk about that as a strategy, and then discuss and touch on a little bit the provider here in Washington. So many of you guys know Children's Alliance and our organization, or our oral health access work falls under our healthcare work. We've been working on making sure that kids in Washington had access to healthcare through our Apple Health Kids Law and protecting that over the last many years. And during that time, we really saw that coverage doesn't always mean access. And so have been for several years trying to figure out how to do a more focused and intentional look on that piece of it. Part of that work is convening the Washington Dental Access Campaign, which covers both kids and adults. A decision to sort of look at oral health sort of seems like a logical step, next step for Children's Alliance. When you look at the fact that oral health disease is the most common childhood disease, and overall improvements in oral health are really obscure the disparities in outcomes, particularly for low-income children, children of color, and children who have English as a second language. And I think that Sarah touched on some of that earlier. That's the same is true for Washington, and those disparities really go into adulthood. Next slide, please. There's been a lot of great reports recently, nationally, and as well as locally, looking at recommendations and solutions, really at and looking at the fact that the majority of people can access oral health care and dental care through the current system of care, so through the private practice model. But in order to look at increasing access to vulnerable and underserved populations, there needed to be a move towards creating a more innovative and patient-centered delivery care model. So when you're looking at any of the solutions and some of the recommendations in this report and others, it really looks at that innovation and more of a patient-centered delivery care model to increase access. Next slide. So take that to Washington, and this is just a snapshot, a couple reports that I pulled out. And when low-income and vulnerable populations are asked, dental care often rises to a top unmet need. And so these reports are really focused on adults, but the same is true for kids. So when you look at the SMILE survey, low-income or children from low-income families are about twice as likely to have untreated cavities, and untreated cavities is kind of a measure of the ability to get care. So if there are cavities within a population and they're filled, then that's sort of seen as the ability to get, but a general measure of access to care is often seen through untreated cavities. So that is much higher in low-income populations. Next slide, please. So many of you are probably familiar with this the study that the Washington State Hospital Association did. They found in this study dental-related issues were the #1 reason that uninsured sought care in the ER and the leading reason for Medicaid. And so this goes back to our making sure that we have a more robust system and care to make sure that underserved populations, low-income populations, are getting care. And this was before adult dental was cut, and so we were fortunate enough in Washington State to have that restoration, and so now we need to really, as a state, when I think the discourse here is really good, and so do the next step and make sure that people are getting the care they need. Next slide, please. So again, many states that cut adult dental as a way to balance state budgets have not been able to restore adult dental, and so the fact that Washington has had the leadership to do that and the groups behind that to support that, to make that happen, is really a great thing here in Washington. We have a lot to be proud of in our legislature for making that move. With that, the restoration of adult dental for the 450,000 that had it cut, there was a small population of adults that were able to that kept their ability. Adult dental benefits. Plus the expansion, we have over 700,000 that are now able to access care or are eligible for benefits. And so again, we need to take the next step and make sure these folks are able to actually get care. Next slide, please. Over 75% of dentists don't see Medicaid. Like Sarah said, and I think David may have touched on, this is not unique to Washington. There's been a steady decline of dentists taking Medicaid for the last decade. There's a lot of creative ideas looking at groups and people looking at ways to boost those numbers, including dentists who are seeing kids to also see their parents, the increasement of reimbursement rates, and other things. All of these would be helpful, but still those are not going to be enough. So this is part of the reason why the discussion around workforce has been talked about for probably decades, but really is growing more and more in recent years. And like David said, there's several states now that are looking at workforce as part of the strategy and solution for improving oral health outcomes for underserved populations. Next slide, please. Just a real quick dental care shortage. These are federally designated healthcare shortage areas in Washington. We have a strong workforce in places, but as was mentioned earlier, those dentists and providers are poorly distributed throughout the state, and there's not enough currently seeing underserved populations. Next slide, please. So Sarah really touched on this a little bit with her talking about the provider, and I wanted to just really highlight some of the work and recommendations and talk about this workforce as a strategy and some of the framework that I thought had been set in several of the recommendations through these reports and a lot of articles that have come out in the Journal of Public Health Dentistry looked at how to improve workforce diversity, to make sure that the providers had appropriate training for serving appropriate training focused on the needs of underserved populations. And I think Sarah touched on that and the ability to have these providers who have a very narrow scope that are really focused in the most common procedures with serving the populations that they work with. A provider that is or solutions that deal with the provider distribution in rural areas and low-income areas, and creating the innovation in patient-centered care delivery model. And I think that Sarah really touched on that with both providers, and that is linked to that off-site supervision and the ability of the dentist and the dental care team to extend care to patient populations instead of the distance that needs to be traveled and getting over those barriers for populations to access the current model of care. Next slide, please. So unpacking that a little bit more and sort of going into a little bit more is how has this mid-level dental provider kind of worked and created and structured to answer the previous slide. And so I just wanted to mention that the first U.S.-based dental therapists or mid-level dental providers really have strong roots here in Washington. The training of the Alaska provider is done in a collaboration and partnership out of the University of Washington Dentex program that really focuses on that sort of PA and sort of MEX model of extending care that's patient-centered care. So it has a long history of success, as David mentioned, over 90 years in over 50 countries. The United States is really the last industrialized nation to bring this provider into the workforce. It's very prevention-focused, as both of them mentioned, but is a little bit different in the sense that this provider can really work as a triage, and sort of they're able to go while they have patients in hand, able to provide care, and if it's more of a has more severe care, they're able to wrap that person back around in to see their supervising dentist. And so that sort of goes into that innovation and how this provider can be used in different settings. There's also another provider that's being talked about. It is a community dental health coordinator, and that provider sort of connects the patient to the dental team. So it's also another role within the team that could be used. We have similar kind of providers here and coordinators here in Washington, but not quite the same. And then the dental therapist is actually a practitioner that's able to treat. This provider keeps the dentist as the lead of the team. It's not an independent really practitioner. It's a little bit different. We do have independent practitioners, hygienists here in Washington. This is a little bit different, and then there's a real close requirement and relationship that occurs between this provider and that dentist, and has that continuum of care within the whole team. Next slide, please. And really quick, the provider here in Washington is really borrowed and based off of the two successful providers, one that is working in Alaska and sort of borrows some things of that model and is adapted to really work for Washington communities, and the advanced dental therapist that Sarah had talked about. So Seattle Central Community College, if you look at the red box, the very bottom provider, that provider does about 36 within their scope of practice procedures, and again, it's the most common procedures, and it's really done in partnership. Seattle Central Community College is working on the curriculum and has worked very closely with the University of Washington Dentex program to create that and mold that to really work for Washington's communities. So the provider is a little bit different than the Alaska provider, but it's based off that model of going into the community, recruiting community members, doing a short intensive training, and then really getting those providers back into the community as soon as possible. And then we also have that sort of accelerated path of advanced dental therapist or the licensed dental hygiene provider that takes the hygienists that are registered dental hygienists and does additional training, and then gets them to be able to do that that sort of dental therapy scope, or that stopping the deep disease through filling cavities and the ability to remove decayed teeth. And so within Washington State, the tooth has to be really loose in order for them to actually remove the tooth. It's not quite the same as the Alaska provider. Next slide. This is actually a video. We don't have time for it, so we can actually go to the next slide, but we can send this out. There's a lot of dentists who are looking at using this as part of their practice in Washington State, and there's a lot of innovation and sort of thoughtfulness around how to do that and sort of make this provider work for underserved communities. And so that video is of some dentists going and sort of visiting the models that currently exist and seeing how that training program is going. And so we can send that out. It's about 4 minutes long. And just I would say to end on this, two things that we again are borrowing from is that community-based provider that's based off the provider that's been working around the world and has been working very successfully for almost a decade in Alaska, and then the provider in Minnesota. And something that's also in the legislation here and the proposal here in Washington that's similar to Minnesota is the requirement that these providers serve underserved populations. And so they'd have to take a certain percentage of Medicaid, very similar to what Sarah said. We believe these providers are going to be working everywhere, but as a strategy and part of the solution for increasing access to underserved populations, feel that that has been very successful there in making sure that these providers are focused when they first come in on where they're needed most. And so with that, I believe we're out of time, but we can maybe try to get a question or two in.
This is Betsy. Tara, we have had one question come in that I think is a very good wrap-up, asking about House Bill 1516 and the status of it. Can you elaborate on that? Is there bargaining taking place, or is there anything that would change that and move it out of committee this session?
The bill for this year did not get out of committee. It will be coming forward, a variation or a version of the bill will be coming forward next year. So as of this year, I think that there is a discussion on how to move this bill forward and keep the integrity of the provider and make sure that it works and serves the needs. And I think that Sarah did a really good job of outlining what some of those things are to make sure it works for it. But as far as this year is concerned, we are really building awareness about this and the dialogue about this as we move forward to look to 2015. And I would say that if folks are looking at ways to be involved, I mean, there's still discussions. I mean, I think that it's great that in Washington State there's more discussion about needs around oral health, but there is a lack of awareness. And so we still have to do some conversations where we are talking about the huge need. And so I think for those within public health that have access to that and awareness around that, I think having those conversations and increasing the dialogue about this is going to be, it's going to continue to be really important. So I really appreciate the opportunity to have this webinar.
Thank you so much. We haven't had any more questions come in, and we are running out of time. If you do have a question for any of the presenters, you can feel free to email them to me at WSPHA, and I can forward them on to the presenters and hopefully get you the answers you're looking for. Thank you for participating in today's webinar, and thank you, David, Sarah, and Tara, for taking your time to participate and share information on this very important issue with us. Our next webinar series, we're actually having a series starting, I believe, in April on leadership skills. So we hope that you will join us for that as well. Thank you very much.
Thank you, everybody.
Thank
Bye-bye.
you.
Thanks so much.